So now we will be starting the session on optimizing embryo transfer outcomes, evidence-based practical approach. So I would like to introduce the moderator for the day, Dr. Pooja Gupta. She's the director of MedLink IVF and IVF Center, and she's a consultant gynecologist at the same place. She also visits Manipal Hospital, Patiala. Madam is a MBBS from Faridkot Medical College, and she has done her DNB in Obs and Gynae from Apollo Hospitals, Chennai. She did her DGO from Dayanand Medical College, Ludhiana. She has done her FNB in reproductive medicine from Nova IVF Center, Ahmedabad. Ma'am is a lifetime member of various esteemed organizations like POXI, ISAR, IFS, and she's a very commonly invited faculty to most of the national and international conferences happening in India. And she has presented various articles in national and state level conferences. Her field of interest is infertility and IVF. Over to you, Dr. Pooja. May I request you to please introduce Dr. Pooja Bihana? You can use
Yeah,
the CV representing. Yeah.
yeah. Thank you so much, Dr. Sarpreet. Thank you for such a nice introduction. So today's topic is very important. Embryo transfer, although is the last step in IVF, but it's a very important step. The stimulation which goes for 10 days, then the ovum pickup, and then incubation, ICSI, and everything goes waste if embryo transfer is not done properly. So learning the right technique from experts is very important. So embryo transfer is very important step. For that, a very good speaker with us, Dr. Pooja Dirbhyana. Dr. Pooja Dirbhyana is MBBS and MD and fellow in reproductive medicine. She is the clinical director of Sonakshi IVF Center at various places at Hisar, Rohtak, and they have other two branches at Kathal and Bhiwani also. And she has achieved various awards and she has got a very important position in various places. Her academic contributions are she has various publications in different reputed journals, and she has also contributed a chapter in Nova IV textbook of infertility, and she has participated as faculty at various national and international conferences, and she has also received awards at ISAR as Young Talent Award in 2023. So she also had some work done in Times Network Award in IVF in 2025, and at ISAR she's got an appreciation award in ISAR 2026. So in IFS 2026. So I welcome Dr. Pooja Dirbhyana. Over to you, Dr. Pooja.
Thank you, ma'am. Thank you so much for the kind introduction. So I think I'll share my screen. Okay.
So all of you can put your questions in the chat box or you can ask them live after the session. So over to you, Dr. Pooja.
My slides are visible.
Yeah, we can hear you clearly. Your slides are nicely visible. Full screen? Are the slides full screen?
I'm doing it, sir. I'm doing it. I'm putting on slideshow.
No problem. Please do.
Fine. So a very good evening. Today we are going to discuss one of the important topics, important ones, critical ones, but I think it is one of the ignored ones also. This is regarding the embryo transfer. We'll be dealing with evidence-based guidelines. We all know that embryo transfer is a critical final step in the process of IVF. You can have beautiful embryos, you can have a very good lab, you can have a beautiful endometrium for your patient, but still, in case the last step, that is embryo transfer, is not the perfect one, your patient may not have pregnancy in that case. And it has been widely accepted that clinical pregnancy rates can vary by up to 25% between different physicians within the same clinic using the same lab and the same patient population. So yes, physician dependency is there. Different physicians will have their different techniques. The problem is each one of us follows our own technique. And there is no standardization. Till now also there are no standard complete guidelines regarding the embryo transfer. So that is why there are variations in the techniques and there are variations in the outcomes that we get out of embryo transfer. This is what has been laid by ESHRE working group consensus, that for a clinician, he should have a minimum of 75 supervised embryo transfers over 2 years, and for an embryologist, he should have a minimum of 50 embryo transfers, supervised loading or transfer procedures during his tenure. So this is, I think, a big number. Every one of us knows who goes from the fellowship program, over 3 years of MCH, over 2 years of fellowship or DNB program. Definitely, I think everybody would agree that you will not get so many of transfers to be done. But the fact is that if every doctor in the unit follows the standard protocol, the unit's overall success rate actually stabilizes and improves. So there is still a room to make a standard protocol. It should not be, I learned this, it should be what the evidence says. So what we will talk today is what the evidence says regarding the embryo transfer. So first of all, preparing your patient. Pre-ET, what to be seen? You need to have a baseline scan for your patient. How many of us are doing scans for our patients on our own? The audience is mute at the moment, I think. Okay, I think someone has raised her hand. So personally, I also feel that this scan should be done not by a radiologist, but a person who is actually looking at the patient, by a reproductive medicine expert. So ultrasonographic evaluation is essential because your ultrasound, you'll come to know what is the uterine position, whether it is anteverted or retroverted. And you can also measure the length of the uterine cavity and the cervical canal, which will be helpful to you during your transfer procedure. You can see the cervico-uterine angle, whether it is anteverted, retroverted, or whether there are any other problems which could be in the form of fibroids or their encroachment on the uterine cavity or cervical canal. So all these things you can look into when you're doing a baseline ultrasound scan. What ASRM says that you should have a baseline scan or a scan in case it has not been done 4 months or 6 months prior. This is regarding the USA. But in India, I think we have been doing our scans. Most of the reproductive medicine people have been doing our scans on their own. So we usually scan our patient prior to our embryo transfer because we have been monitoring them for their embryo, for their endometrium. Now, for definitely you have to prepare your endometrium for the patient before you move for the transfer. Second point is always do a mock transfer. This is my personal opinion. In my initial days of practice, I didn't used to have mock transfers. Then one fine day, I was stuck up with the patient. I was not able to negotiate the cervix. At that time, I realized that a mock transfer, which takes only 5 minutes, is good to have rather than अपने आप को फंसाने में in the final point. So it's good to have a mock transfer prior to having the real transfer for your patient. It is recommended by ASRM as well as ISAR. At what time it should be done? You can do it in the prior cycle, or you can do it at the time of OPU, or you can do it immediately before the live ET. Live ET, you can, prior to initial cannulation, prior to your original cannulation, you can actually pass on a smooth cannula. What sometimes I do when I'm fearful that I might be stuck or the triality has been done by some other person, I usually try to negotiate just till the internal loss with the help of a IUI cannula. So in case I'm able to pass through the IUI cannula, I think it's all done then. Then you get the final transfer cannula. Then the mock transfer actually tells you about the uterocervical angle. It matches the cervical canal length and identify internal stenosis in case there is any, which will help you in future planning for your patient. And evidence says that in case you have done a mock transfer for your patient, it reduces surprise difficult transfers, which may be associated with almost 20% drop in pregnancy rate. This is a study long time back, but it still holds good at the present moment also. Now you need to have a decision regarding the number of embryos to be transferred. Either you want to have a single transfer for your patient, you want to have 2 embryos to be transferred, or you want to have 3 embryos to be transferred. This is to be a collective decision between the clinician and the patient. As far as X-ray is concerned, they straightforward say that you need to go for elective single embryo transfer for all the patients because the benefits of elective SCT are far more than double embryo transfer, and the complications that are seen with double embryo transfer, they can be combated in case you go for elective single embryo transfer. You, by going for elective single embryo transfer, you actually decrease the complication risk for the mother as well as the baby. And cumulative pregnancy rates, in case you see the cumulative pregnancy rates of elective single embryo transfer and double embryo transfer, they are almost equal. So it's just a mindset, I think. We, at the moment, I think most of the centers have been doing 3 transfers or 2 embryos to be transferred. Single embryo transfer could be a policy at some places. At my center also, we have been doing single embryo transfers, not for all, but for selective patients. But yes, thought is still of double embryo transfer, which I think should be shifted towards single embryo transfer in case we are working in good conditions. Indian scenario, as I said, we are still towards 2 or 3, and it needs to be shifted. Definitely it needs to be shifted so as to have a safe maternal and neonatal outcome. As per ART guidelines, the maximum limit that has been there in the ART law, it is 3 embryos to be transferred, maximum of 3 embryos to be transferred in a single patient. Now you have selected your patient. You have done everything for her. You have done triality for her. You have monitored the endometrium. Your patient is ready for the transfer. She comes on the day of transfer. What to do at that time? There are certain points that need to be checked. First of all is identifying your patient. First of all, identification is the most important medico-legally also. किसके embryos किस में जा रहे हैं? A good identification or a wristband, whatever is the protocol at your center. I always inquire about the medication from the patient, whether she has taken the medications or not, or is there any difficulty in medication. Then consents have to be taken. We all know this is definitely important as far as we are in the medical legal era at the moment. And of course, reconfirm the number of embryos to be transferred. Again, reconfirm from the patient, single transfer, double transfer, whatever the patient wishes to have. Then the patient has to be asked to have a full bladder. Why full bladder? Because most of the transfers are done under ultrasound guidance. And for this ultrasound, when you have a full bladder, it gives you a window to see the uterus. So you are able to see the uterus nicely when you have a full bladder. And of course, when you have anteverted uterus, it straightens the angle. It makes your passage of the catheter very easy. In case you are having a full bladder, it makes anteverted uterus slightly towards the straighter side. But in case it is a grossly retroverted uterus, then the full bladder might not help you. It may actually make the transfer more difficult. So in retroverted uteruses, I usually try कि इतना full मेरे को नहीं चाहिए bladder. It's only that you are able to see. It is only for the acoustic window that you have a full bladder. Mind it, your patient should have a full bladder, not a bursting bladder. पेशेंट कई बार आप ओटी रूम में जा रहे हो, अपने ईटी रूम में जा रहे हो, तो क्या हो रहा है कि पेशेंट विल बी लाइंग डाउन ऑन द टेबल and she'll be holding her bladder for a long time, and she'll be holding her abdomen कि she is having lot of pressure. This is actually a negative thing for the patient as well as for the transfer procedure. Why? When the patient is uncomfortable, she'll not be able to relax. Secondly, you will not be able to see the uterus very nicely in case it is extremely full. And also you'll have uterine contractions. These uterine contractions can have a negative impact. It can lead to drop down of your air bubble. And sometimes this full bladder may also lead to cervix will be high up in those cases. Sometimes you are not able to see the cervix. You just empty the bladder and you will be able to see the cervix very nicely because the cervix had been pulled up because of the full bladder. So it has to be a nice full bladder, not a bursting full bladder. The patient has to be comfortable, that patient is comfortable, you are comfortable in seeing the uterus, and you are comfortable in seeing the cervix also. The standard care at the moment is ultrasound guided transfers. I think everyone has been doing ultrasound guided transfers. Long time back, there were tactile touch transfers. People used to measure the cervical length. People used to measure the uterine length. And then they used to keep the catheter like that. They used to measure all those lengths and then keep the catheter under the fundal area. But with ultrasound machines, it's quite easy. We are able to negotiate it easily. We are able to see the angles. We are able to see the length. So it's quite easy, and it has actually improved the ongoing pregnancy rates and live birth rates. This is something, ultrasound guidance is something which comes into grade A evidence. And it has been seen that implantation rates, pregnancy rates, ongoing pregnancy rates, live birth rates, all are improved when you are using ultrasound guided embryo transfer as compared to tactile touch. So make it a practice. In case you are doing a transfer, keep ultrasound ready so as to get it done under ultrasound guidance. Now you have shifted your patient to the OT room, ET room, and your patient is having full bladder. You are all ready for the transfer. You have nicely set the image. Ultrasound guided transfer, you need to set your image. It should be actually optimized image. It should not be a very small image. You need to have a look at you need to have to look at a larger view. So we always zoom the image so as to have a better view. Now, whether to use powder-free gloves or powdered gloves. In case you look at literature, there are not much of studies, but there was a single study that is there, which is quoted in ASRM guidelines also. And it has seen that powder-free gloves or powdered gloves, they don't have any impact on the pregnancy rates as long as you don't have any direct contact with the embryos. Powder is definitely toxic to the embryos, but when you're wearing the gloves, you are actually not touching them. So it may not have any long-term impact overall on pregnancy rates when you are using powdered gloves. Now, catheter types. You are ready. You have worn your gloves. The next thing is, I'll discuss the catheter types. Next thing is you will be putting the speculum also. But the catheter types, which one to choose? There are various types of catheters. The ideal catheter is the one which is soft and flexible. It should be actually non-embryo toxic. It should be easy to maneuver and free of bacterial toxins. And of course, it should be visible on your ultrasound. When you are putting your ultrasound probe, you are able to see the catheter moving inside. This is what we know by visibility. Now, the catheter types can be single versus double lumen. Single lumen is you will have a single lumen catheter. You put the embryos inside and you try to negotiate it. But these are outdated nowadays. What is the industry standard is the double lumen catheter. All have been using double lumen catheters. I'll be showing it to you. And the others are hard versus soft catheters. Hard catheters are, I again think nobody is using. We are only using soft catheters because we all know that hard catheters, they cause more of trauma, and soft catheters have been proven to have a better outcome as far as IVF is concerned. And then you have echogenic catheters. Echogenic catheters make the visibility much more easier on ultrasound. This is how the catheter looks. There are different types of catheter, different companies, and all will have their own designs, but you should use whatever you are comfortable with. A softer one, definitely a softer one, a double lumen catheter, whichever you are comfortable with. In case, okay. Can you see this? I'm not sure if I am able to make it clear. Am I visible? Is this catheter visible?
Yes, ma'am.
Yes,
Okay.
ma'am.
So this is the catheter we have. This is a standard catheter I have been using throughout. I'm saying there are many more designs also. You can have your own, whatever you are comfortable with. You can shift to Wallace, you can shift to Cooks, whatever you are comfortable with. So this is the catheter we have been using. This is the outer sheath. This is what is the outer sheath, and this outer sheath acts like a rail. It acts like a rail because you are able to negotiate the cervix with it. So this outer sheath will negotiate the cervix and it will protect the inner catheter from all the cervical mucus. This is having a bulb. This small bulb will help you negotiate the cervical crypts very easily, very finely. And it has a guard. This is the guard, and you can adjust this guard accordingly. Then there is the inner. This inner catheter is the one which is softer one. All the catheters which are having inner catheter which is softer are classified as the soft catheters. And this soft one, in case you see, this is having partly a very soft part and part of it is metallic one. This metallic one is actually something which helps you to hold it. In case it is like it is soft, throughout the end. You will not be able to manipulate it. You will not be able to carry it. Actually, it will be very difficult to put it inside the outer sheath. So this holds it, and it has markings. There are 4 markings. In case you are able to see, there are 4 markings, 1, 2, 3, and 4. So you cannulate first the outer catheter. You have the inner catheter in place, and you have to load your embryos here. With loaded embryos, you go like this. And when you have reached the tip of the outer catheter, your first marking will be, you'll be at the first marking here. In case you negotiate it or you advance it further, you will be actually reaching the endometrial cavity. So from these markings and from ultrasound, you can actually come to know where you are inside the cavity. In case sometimes in very obese patients, it may not be very easy to visualize the catheter. Then in case you know that you have negotiated the cervix, these markings are sometimes of help when you are not able to see it very clearly. I think partly I have clarified. So again, this is what is the inner cannula. This is the outer one. The outer ones may be curved or they may be straight. This one is curved. Some other catheters are straight ones. And in the middle, what you can see is the obturator. This is the obturator. This is something which is hard, and this is used for difficult transfers. Wallace catheters, they come with obturators also. They have inbuilt obturator with them so that you cannulate first, remove the obturator, then put the inner cannula inside. So there are different types of catheters. Soft, as I said, softer ones are the practice at the moment. And it is a level 1 evidence by ASRM Practice Committee 2017 that why softer ones? Because it leads to reduced uterine contractions. Softer ones will be actually gliding. They will be gliding into the uterine cavity. And when you are using the hard catheters, कभी हल चलाते देखा किसान को तो वो हल जैसे करता है, it flows inside the endometrial cavity. So you'll be causing micro trauma, mucosal trauma when you're using hard catheters. So the best ones are to use the softer ones so as to have a better outcome. And it has been seen in various trials that there is significantly increased clinical pregnancy rates when softer catheters are used as compared to hard catheters. This is the Cochrane review. Now, there are certain more catheters. Sometimes the difficulty used to be when you're using a normal catheter, the visibility could be poor. So to improve visibility, what is done is either the catheter companies would make an echogenic tip or they will make whole of the catheter echogenic. So these are echogenic catheters. Echogenic tip helps you to identify at which point you have reached inside the endometrial cavity. You are able to identify the tip and then you can inject. Then certain more catheters, Wallace one, SurePro one is having small air bubbles inside the catheter. So you are able to see it throughout the length of the uterus. So these are the ones which are easier to identify. But which catheter to use, it's not going to make any difference. As I said, studies have not shown any difference with one specific type of catheter. You can use any one depending upon your comfort, your expertise, and of course, the finances that are involved. So this is just a small slide where you can remember that for easy transfers, you can use soft double lumen catheters. When there is poor visualization, you can use echogenic tip. And for difficult or acute angle, you can use a stylet or a sheath. When I say a stylet, how do we use a stylet? Suppose I am having very difficult transfer and the uterus is acutely anteverted. You know the position is like this. In that case, you can use this catheter. Along with it, you put your stylet inside. And with this stylet, you can actually mold the catheter. You can mold it according to the shape. And then you can traverse it. Being hard, it will be easy to pass through and it will retain its shape. It will retain the shape in which it has to go. And once you have negotiated the internal os, you just remove this stylet. You keep this catheter inside and then you insert the inner catheter. So this is how difficult transfers can be done with the help of a obturator. Okay, I think procedure partly I have covered, but for the procedure, your patient will be in lithotomy position. The patient will be in semi-lithotomy or lithotomy position, and patient has to be comfortable enough with her bladder. You look into the cervix, or you have a look at the cervix with the help of a cuscos. Cuscos is a preferred one because you don't need to hold the cervix in that case. It has to be a gentle process, and whenever you are transferring, you have to avoid touching the tip of the fundus. Why? Because any kind of uterus has to be quiescent during the phase of embryo transfer. And once your contractions are there, it is going to push the embryo out in case it is having hypercontractility. So yes, you try to be as silent as possible. You try to put your uterus as silent as possible during the transfer. This is by gentle touch, by using cuscos, by avoiding holding the cervix. We usually do our transfers without holding the cervix unless it is going to be a difficult transfer. Then avoid touching the tip of the fundus. This can give you an atraumatic transfer with better outcomes. I still remember my teacher teaching me that the best transfer is the one that the patient doesn't feel and the uterus doesn't notice. So yes, you need to standardize your technique. My teacher used to say that आपको इतनी प्यार से ट्रांसफर करना है कि जैसे चोर अंदर घुस के चोरी करके आता है ना, घर में पता नहीं चलता किसी को, तो आपको चोरी से अंदर जाना और चोरी से बाहर आ जाना है. This is a wording he used to say. Now you are looking into the cervix. You have seen the cervix. Mucus plugs are there, and this mucus can be harmful or detrimental for your transfer. This is actually a silent killer for your transfer. Why? Because it can plug the catheter tip, and it can lead to retained embryos, and of course it can lead to introduction of vaginal bacteria inside the endometrial cavity. So you need to clear this mucus. This mucus can be cleared with the help of cotton swabs, and each one has its own practice. Some people will be using dried cotton swabs, some people will be using some media on the cotton swabs. So it's all up to you, whatever you are comfortable with. But then again, you have to be quietly doing it, no aggressive scrubbing. You don't have to irritate the uterus because it may then lead to uterine contractions. It can trigger bleeding and release of inflammatory cytokines, which can have a negative impact on your embryo transfer procedure. So removing mucus definitely benefits. And in case you have mucus, just check the catheter tip for the mucus. If the tip is plugged with mucus, you know the risk of retained embryos could be as high as 10 times. So this mucus has to be removed as much as possible, not overdoing, but definitely whatever you can do. Now loading and transferring. This is the part which is going inside the lab. You are cleaning the cervix, you are ready for the transfer, your embryologist is getting ready for the embryo loading also. So the embryos, when they are loaded inside the catheter, you don't have to take the catheter as such. You have to pre-warm them, the catheter and the transfer media. This must be pre-warmed to 37 degrees Celsius, and loading into a room temperature catheter, it can actually cause a cold shock, which can be detrimental for the embryos. Embryos are highly sensitive to light, and you need to take care that you have to dim the lights of your embryology lab also, as well as your transfer room also. So light and pre-warming are the things which are needed to be taken care of. Embryo loading, you have two types. One is a single step. Single step is preloading, what we call as preloading. In single step, the embryologist will actually keep this inside. He will have the outer and the inner outer sheath and the inner catheter. He will load the embryos along. He will come to you like this. He'll load the embryos. He'll put the inner cannula inside the outer sheath, and he'll bring to you the whole of the system, the outer and the inner together. And then you pass on into the cervix, into the endometrial cavity. But then later on, yes, of course, after loading, in case you see, after loading is something which I explained initially, that you put in outer sheath initially, and then you put in the inner sheath with the cannula. So after loading is definitely better because when you are putting in the outer sheath, you are not exposing the embryos to harmful cervical mucus, which could be there. When you're putting this first and there is any difficulty, you are not exposing the embryos to trauma also. So it helps you to negotiate easily. And once you have negotiated, just give a call to your embryologist that you are ready. The embryologist will then load the embryos and then come to you. This decreases the time as well as this decreases the trauma that can be there in case you are having some difficulty in the transfer. So after loading is something which I have shifted. I was initially into preloading, but as I told, I had certain experiences. You learn by your experiences and your work. So I shifted to afterloading later on. It's actually very good. You are able to negotiate, you are able to manipulate without any harm to the embryos. So preloading, afterloading, definitely afterloading is better as far as your embryos are concerned. Just think that your embryo is a VIP. In afterloading, you never roll out the red carpet until the doors are already held wide open by the outer sheath. तो आपका VIP embryo जब आ रहा है उससे पहले सब आपका pathway clear होना चाहिए. This ensures that embryo's journey is a sprint and not a marathon. Fine. Then your embryologist is ready to load. You have given the call. Load now. You come now. So he'll be loading. The ideal volume to load. What is the ideal volume to load? It is around 10 to 30 microliters. And large volumes, more than 60, when it is there, it may have a negative impact because then your embryos will be flushed inside the tubes. Your patient may land in ectopic pregnancy or a negative result in that case. So more than 60, not a good thing. Even less than 10, sorry, this is not 1, this is 10 microliters is also shown to have lower success rates. So ideal is to have 10 to 30 microliters. There are various methodologies of loading. Sometimes you'll be loading only, your embryologist is loading only the fluid and the embryo. Sometimes you'll be loading the air fluid method. So in the air fluid method, you have air pockets along with the embryo, medium with the embryo. So there are different ways of catheter loading in the air and fluid method also. Sometimes you'll be air first, then medium with embryo, then air again. Sometimes you'll be medium, air, medium with embryo, air and medium. This is all done by the embryologist, whatever he's comfortable with. And sometimes you'll be loading only with the medium without any air bracket in it. As far as the techniques are concerned, there is no difference between these loading techniques. There are various studies which have seen that there is no difference between the outcomes when the loading is done either with medium with embryo alone or with air medium type. Now, where to deposit? Your embryologist has loaded. He is coming to you. He has given you the embryos, which place to deposit. You are ready with the embryos. You have cannulated you have put your cannula inside the outer sheath. Where to deposit? The final thing that is there is the sweet spot where your embryos need to be there. Your catheter, it has been seen that your catheter, when it is in the upper third or middle third of the cavity, it will give you the best results, but it should be actually not in the vicinity of the uterine fundus. It should be 1 centimeter away from the uterine fundus. So 1.5 to 2 centimeters from the fundus is the area where you have maximum implantation potential when you have your catheter in this area. So try to put your catheter in this area, not very high. When you're going very high, you will be touching the fundus. In that case, you will be triggering microcontractions, which can actually throw your embryo out or into the tubes. And when you're putting it very low inside the cavity, again, the implantation potential will be lower. Your embryo may not be able to implant in this area again. Then you have put inside, you have selected your position, you have put in your cannula inside at a safe place, at the sweet spot where the embryo is going to implant. How to inject? Have you seen कभी शांत वाली देखी आपने रिवर और कभी एक बहुत तेज वाली रिवर
Dr.
देखी आपने?
Pooja, sorry to interrupt. Actually, there are many international students, so if you can talk in English, I mean, I know
Okay,
these are
okay.
good anecdotes in Hindi, but they are unable to understand. They've written in the chat box to, kind of.
Fine.
Sorry for that. Sorry,
Okay,
ma'am.
sir. No, sir. So you have to inject. Your injection has to be very smooth. It has to be like a feather touch. Why? Because in case you're pushing it very hard, you will be making the fluid inside into a turbulent flow. And this turbulent flow can actually damage your embryos. And it has been seen that it leads to increased apoptosis in case you are very fast in your injecting part. So you have to be gentle. And once you have pushed, either to wait or not to wait. There are studies where people have waited for 30 seconds, where people have waited for 60 seconds, and they've compared the outcomes without waiting and withdrawal of the catheter immediately. So you can immediately withdraw the catheter. There are no differences in the outcomes. A 30 to 60-second delay is not actually required. It offers zero benefit for pregnancy rates. So you have pushed, you can actually remove the catheter without much of delay. Then when you have pulled the catheter back, make it a point that you pull the outer and the inner together and hand it over to the embryologist. The embryologist will then take it back into the lab and he will again inspect the catheter for any kind of abnormalities, which could be in the form of mucus, which can be in the form of blood, and more importantly, retained embryos. Now, when you have put the embryos inside, it's good. But when sometimes you have retained embryos, what to do? So your embryologist will be telling you that I have something which is retained, 1 embryo, 2 embryo, and you need to put it back. So the embryologist will then again put them back into the canal and you can retransfer them. It has been seen that retransferring the retained embryos is actually good. It may not harm and it leads to good pregnancy outcomes in case you are retransferring these retained embryos. So what we do is I keep on my cuscos inside. I think everybody does that only. You have given back the cannula, your cuscos is inside only. Your cannula is going to the lab, it is being observed by the embryologist, and once the embryologist says it's clear, then only I try to remove that cuscos. And in whole of this scene, it's very important that you manage your timings. Your embryos are extremely sensitive to all the environmental changes. They are inside the incubator, which is a good condition for them, and you're taking out. Whenever they are taken out, they have some kind of shock, maybe in the form of temperature fluctuation, in the form of pH changes, or in the form of light. So whole thing has to be in a well-planned and well-timed manner. And it has been seen that the more the time the embryos spend outside, from the incubator outside taken and then inside the uterine cavity, in case more of time is taken for these embryos to be transferred, it is going to be detrimental. 90 seconds is something which is still, I would say, tolerable. More than 120 seconds, in case it is taking more than 2 minutes for you to transfer your embryos out of the incubator, then it is going to be detrimental for the embryos. It is going to be detrimental for your outcomes. So try to be as fast as possible. In one of the studies, it had been seen that load to release time of less than 44 seconds yielded the highest implantation success for the embryos. This is what I was talking about. When they are out, there will be temperature fluctuations, there will be pH changes. Your pH of the media will be changing to more of alkaline and there will be exposure to light. So you have to minimize this by minimizing the timing they are spending outside the lab. Now, post-procedure, what to do? 10 years, 15 years back, I think there was a practice that patients used to lie down straight. They didn't have to move. They had to lie down on the bed for 24 hours, 4 days, whatever. But it has been well seen now that immediate ambulation actually improves your pregnancy rates. Immediate ambulation is something which is good for your patient because bed rest, even of 10 minutes, is not going to improve the outcomes. So this uterine cavity is a small space. It is not something which is a big space. And the embryos are, when you are going inside the endometrial cavity, you are going to just put the embryos inside a potential space. It is not something that the patient will stand up, the gravity will pull them down. It's not like this. So just transfer. You have checked the embryos are fully transferred. They are not retained. You have removed the cuscos. Your patient can be ambulatory. She can take out her routine activities as soon as possible. Now, what to take, how to tackle difficult transfers. I think we have discussed regarding the obturator. So difficult transfers could be because of the cervical factors. It could be because of the uterine or pelvic pathologies, prior surgeries or extreme retroversion, or it could be patient factors. Patient is having vaginismus. In that case, you should come to know. One, I would just share something that even if a hysteroscopy is done for my patients, I try to do triality. Although I know I can negotiate the cervix, but then doing a triality helps me to make myself clear that the patient is comfortable with the transfer without anesthesia, or she will need anesthesia during the transfer. So this is one reason I go for triality for all the patients, even after when I have done a hysteroscopy, in case it is done for a patient. So you face a difficult transfer, how to handle it? First of all, you can use a rigid stylet that I showed you. This is something, the obturator is there with you for your help. You can negotiate with the obturator. You can hold the cervix with your valsalum, and sometimes with all the efforts you are not able to negotiate. In that case, it is best to have, at the moment, in the present era, I think we have excellent facilities of freezing. So rather than having a difficult transfer, it's better to freeze the embryos and then go for a hysteroscopic assessment, and then go for transfer for this patient. Transmyometrial transfers we have been reading, but practically I have never seen and I have never done. So I have nil experience in transmyometrial transfers. I would rather freeze the embryos and go for hysteroscopic dilatation for the patient, hysteroscopic guided dilatation, and then finally you will transfer the embryos in the next sitting. Now, any role of uterine relaxants? It has been seen that when the junctional zone contractions are more frequent, more than 3 per minute, they can be detrimental to the outcomes. So with this in mind, people have used atosiban, which could actually lower the contraction frequency to less than 1 per minute. In some of the trials, it has been seen that it may increase the clinical pregnancy rate and live birth rate in those with repeated IVF failures. But yes, it is not recommended as a blanket therapy for all the patients. The best thing to do is to have an atraumatic gentle transfer rather than having atosiban in place. Atosiban will not make any difference when you are doing a transfer which is traumatic. This mechanical trauma is anyways going to make your uterus more hypercontractile, which will not be nullified by use of any kind of chemical agents or these pharmacological agents. So best is to have an atraumatic technique rather than relying on the pharmacological things. Now, adjuvants that are there, anesthesia, antibiotics. Antibiotics had been given in the past because we used to think that it could lead to some kind of infection, but without any kind of indication, don't need to give antibiotics to your patient. Anesthesia is routinely not required unless, as I said, the patient might be having vaginismus. In that case, you may require anesthesia. Or it's in my difficult transfers, whenever I know that I need to manipulate the cervix more, in that case also I prefer giving anesthesia to my patients. Now, embryo glue, whether to use or not. Since past few years, there is a hype, I would say something. I don't know. I've never used it. That is why I'm not very much convinced with it. Embryo glue has been into picture. This embryo glue is something which is hyaluronan enriched embryo transfer medium, which aids the implantation of embryos. And it can be actually used in all stages of embryo transfers. What it does is it actually matches the viscosity of the uterine fluid. So when you are transferring, you'll be transferring in a fluid which easily mixes with the media you are transferring with, and it will lead to more of retention of embryos, and it aids in receptor cross-linking. There are CD44 receptors on the blastocyst also and your endometrium also, and it cross-links this receptors on the blastocyst and your endometrium. That is why it helps in better implantation. And of course, this media is enriched with albumin and other nutrients which provides embryonic support. So yes, what the evidence says at the moment, that even Cochrane review says that this hyaluronan-rich media can significantly increase the live birth rates, especially in repeated implantation failure patients. This can be of use. I have not used it, so no practical experience, but this is what I read. And for these embryos to be transferred, they have to be placed in the glue for 10 to 30 minutes before embryo transfer. And you use a standard sandwich loading technique for the embryos to be transferred. But mind it, it's a bridge. It's not a fix. Why? Because this is something which will help in adhesion. But when the endometrium itself is not receptive, it's suffering from something which is making it non-receptive, could be chronic endometritis, or your embryos are not good. When the embryos are aneuploid, it is not going to act as a miracle. So yes, your endometrium and embryo, they need to have a crosstalk. This crosstalk can be helped with this hyaluronan-rich media, but it is not a 100% guarantee. Like Some of the patients will be asking, embryo glue in case you use embryo glue, it's going to be 100% effective. It's not like that. So you need to understand this. I think this is, in the end, I would just like to say that there are some golden rules for your transfer procedure. It has to be atraumatic. Do it under ultrasound guidance. Use a soft catheter, not a hard one. You see proper depth where you are having your inner cannula inside the cavity and leave the embryos at that sweet spot. It has to be fast, minimizing the time of exposure for your embryos, and it has to be standardized. In case you are working in a unit, it has to be standardized for all the consultants so that you can have a better outcome for all your patients. It should not be going my way. It should be what evidence says. Thank you. This is all.
Yeah, I think Dr. Pooja, you have covered almost everything and it was a beautiful presentation. I must say, I really appreciate. You have covered everything in your talk, all the basic techniques and everything, all the evidence also. Still, if there are any questions, I think we can look into the chat box. Any benefit of emptying the bladder before the patient gets up from the couch? I don't think so. We do that. Dr. Pooja, would you like to answer on that?
Ma'am, can you, anybody emptying the bladder before the
patient gets up from the couch after doing everything?
What is
No,
name?
when the patient gets up from the couch, she can go to the washroom on her own. You don't need to empty the bladder because inadvertently you will be introducing some kind of infection. I don't like to catheterize my patients. I don't want to introduce any kind of infection. So let her get up and go to the washroom.
So do you encourage cleaning the vagina and cervix with warm saline or just cleaning the out with cotton buds or media?
This is something which I was reading that people have been cleaning vagina and cervix with warm saline. I have not been following this. I don't know. This is, again, I say, there is nothing of that sort, but I have never used any kind of cleaning agent. I just use dry cotton swabs to clean out the mucus. And sometimes when the mucus is thick, you just syringe it out.
Another question, how after transfer, when can patients travel? Like
She can travel. She can travel. There are no restrictions at all. Look, whenever we are doing IVF, the first thing I make my patients clear is that IVF is not going to change your life. In case she is working, she can go to her job. In case she is going for travel, she can travel. In case she is coming from outside India for transfer, she can go back. So there are no restrictions. There are studies where people have seen the ultrasound. We see the embryo, not the embryo, we see the bubble inside the air that is there. We see inside it with the help of an ultrasound. And there are studies where people have observed this air bubble 60 minutes after and a long time after the transfer. And the positions are not actually changed by the movement or standing up. So whether the patient stands up, she walks, or she goes to washroom, it is not going to make any difference.
I would just like to add on, Dr. Pooja, like although evidence shows that there is no benefit, but I have seen a lot of psychological impact on patients' mind. So if we ask them to take rest for 5 minutes, they'll be psychologically satisfied that we did not get up immediately. That's it.
This is true. This is true for our setup. Definitely true. I agree to it.
Yeah, so it's possible we can tell them 5 minutes, they can stay inside the OT, and after that they can wait outside in the recovery for some time, and then they can wait in there. So then we have psychological satisfaction that this is enough bed rest because we know the positive and negative both are going to come. So whenever their results are negative, they start going back to their transfer day. This happened, I got up immediately, I passed urine immediately. So we have to keep them mentally satisfied also. So like that, although we counsel them that these things we don't exactly. So
this is why I think our counseling starts right from the patient comes into our OPD for IVF. So your counseling starts from that. And believe me, most of the patients are afraid of getting IVF just because we advise bed rest to them. This was a practice long time back, maybe 15, 20 years back. Patients used to be lying down on their bed without any kind of movement. And it was, when I entered into practice, I was in one of the centers where this used to be there. And I looked into the patient's condition. I used to feel pity on them. And one thing I really hated was that they used to lie down. They used to have their food while lying down. They used to have their bedpans with them. So it was
Yeah.
deplorable actually. So
Yeah,
practice has
yeah,
changed since then, and it's, I would say, IVF has become more patient friendly, and
yeah,
definitely a boon for working females who could not think of getting IVF done just because they would have to leave their jobs at that time.
yeah. Do you see any harmful impact of blood seen after transfer on outer or inner catheter? Do you note that? Do you make any note of that?
Yes, we have a proper sheet where we note down everything. Where I have the embryo grading, where I have that what has been used, Cuscos has been used, difficult transfer, easy transfer, whether I had to use Valsalom, whether I had to use any kind of other help in the form of obturator, the tip was clean or not, and what was the position of the bubble. So I always note it down in my sheets. And whenever a patient is negative, suppose a patient comes with a negative report, I have a habit of looking into the embryology sheet, looking into the old records of mine also, and the clinical records as well as the embryology sheet. That whatever has been done, let us have a look what had gone wrong and what can be implemented or improved in future.
So I think, is there any more questions?
Yes,
Anybody who can
yes,
unmute them?
yes. Others
Yeah.
can ask questions. Hello, hello.
Hello.
Yeah, yeah.
Yes, I just want to ask if blood in catheter, endometrial thickness before transfer, does it have any relationship with the incidence of blood in inner or outer catheter? Yes, and
Can you
some of the wireless or some of these medium catheters, do you have to curve them at the tip before putting in? And then you have to shift the stopper because some people have had myomectomy, they have very long cervix, and then you push it in the cervix. Or how do you make sure that you don't have blood? Because it's most of the people with blood in catheter, 80% of them get negative pregnancy test. I don't know whether it's a myth or a reality.
look, in case you have, in case I'm able to understand your question, I'm just repeating your questions. You are asking about the bleeding, whether it has a negative impact or not. And the second thing
Yes,
is you
and
are asking about the guard which has to be put. Am I
yes,
right?
I'm asking the first important question is, do you know why we have whether the endometrial thickness before transfer, it should be between 8 and 14. What is the level that may limit the incidence of blood in catheter? Does it have a relationship with the endometrial thickness as at the time of transfer?
I think in case you are transferring very thick endometrium, the endometrium is highly estrogenized. It is highly fragile. In that case,
Mm.
sometimes you can have bleeding despite having a very gentle kind of transfer. This is sometimes which I observe.
So
I don't know
what do
about
you
literature,
recommend
but this is
then
something
as
which is
an
there.
expert? What do
And
you recommend
secondly,
as an expert?
you transfer when an endometrium is 8 or 9 mm. Don't make it thicken to 14 mm or 15 mm. Don't wait so much long time to give estrogen. Sometimes when the people have been doing something in batches, in that case, you may have to wait for a longer time for endometrium to grow. But in that case, when you are giving more of estrogens, it may be more of estrogen, more of thickened, more of fragility, and then it may lead to bleeding during the transfer. So personally, whenever I see a very thick endometrium, I usually try to shift to next cycle. In case it is, sometimes you'll be able to see the thickened endometrium even on 10th or 11th day of your estrogen in case you are going for HRT. In that case, you just decrease the dose in the next cycle. So we just alter the
Okay,
things
so the
accordingly
ideal,
as we see.
yes, the ideal measurement is about 10. Is that what you're saying? The ideal
It's
measurement, is it
it's
10 or 9 or 11 or 12?
there is nothing ideal. And the minimum cutoff that we take is the 7 mm or the 8 mm benchmark that is taken. But then there are patients with thin endometrium also whom you are not able to grow the endometrium despite all the efforts. The best thing is to go for the transfer for them in the best endometrium that you can grow. And when you're putting in beautiful embryos, such patients also conceive to a great extent. So there is
So
nothing which is
what do
ideal
you,
for the endometrium, I would say.
okay, nothing is, has a more pregnancy outcome, like the more, maybe
Pregnancy
12 or
outcomes are,
10.
yes, definitely better when you have more than 7 mm. I'm not negating it. But when the thickness is less than 7 mm, it is not a reason to defer transfer to a patient. Until unless You have ruled out everything. You have done a hysteroscopy, you have given probably a metroplasty to her. So, in case the endometrium is still low, you need to transfer after explaining all the consequences to the patient. And practically, yes, in my experience, such patients also conceive despite having thin endometrium in case you give them good embryos, good blastocysts for transfer. The second question you asked was, sorry?
Some catheters, do you have to bend? You have to bend them towards the tip to negotiate the curve of the cervix before using, or you put them straight like that? Bend,
No,
bend,
most
curve.
of the
You have
times
to
you will be
curve.
able to negotiate the cervix without bending the catheter. In case you have acute angulation, in that case you may mold it, but these catheters are not very much malleable. So in case you want to mold it, you may need to have an obturator inside. The second thing you asked was regarding the guard. This guard is there,
Yes.
and in case of very long services, what is my practice is when you are doing it under ultrasound, you actually don't need a guard. This guard
Yeah.
is useless when you are doing it under ultrasound. You know where you are traversing and where you have reached the internal loss. So I usually try to pull the guard back only. I'm not using this for measurement of my cervical length, or it's actually of no use to me practically until unless I'm doing it under blind transfer without any ultrasound guidance, which I don't do actually.
Is there anything like maximum implantation potential, area of maximum implantation
Yes,
potential?
yes, yes. This is what we discussed. This is what we discussed in one of the slides. Your catheter has to be at a place which is around 1.5 to 2 centimeters below the fundus.
Okay, okay. Thank you. Bye. Thank you very much.
You're most welcome, dear.
Dr. Pooja, somebody is asking about the serum progesterone level. Do you do it before embryo transfer?
For fresh transfers, yes, you take the cutoff to 1.2. For frozen ETs, I have been doing my serum progesterone levels. For HRT cycles, around 0.5 I take, although 0.7, 0.8 you can still transfer. But I take my cutoff to 0.5. And otherwise, for stimulated cycles, suppose I am doing frozen embryo transfer in a stimulated cycle where I have used either letrozole or tamoxifen. In that case, the cutoff increases. In that case, I take my cutoff to 1.2 only. I do get my progesterone levels for the patients before the transfer is done.
Okay. Yeah, I think everybody from with you. So usually I think on an average, one is taken as a standard level. So if
Sorry?
it is above one, it is usually above 1 nanogram. If it is progesterone levels are above one, then usually try to cancel the transfer.
This is what, in case you are stimulating your patient, then I usually try it could be 1.2. This is all variable. Initial study said 1.5, then it came 1.2. So it's all I think your experience, whatever is there.
So I think there are no more questions. So thank you so much, Dr. Pooja. You have given such a beautiful talk, and I think everything is clear about. And I think more of the practices are like they follow are the same. Like I also follow simple steps. I don't use any fancy things like a atoxidant and all. I will never try. But yeah, I think there are some new which we must try. So that's how the new practices come into the picture. Like embryo glue and all in previous implantation failure. I think we must try once in a while in previous implantation failure. Because before we proceed to next cycle or anything else, as we have nothing else to do, so we can try with these patients who have undergone 2 or 3 implantation failure. We can try embryo glue in such patients. So that's how the new research, they will have some outcome, we will have some disease. Like in future, we can have some things to learn like what we will do. So
Yes,
that's
of course. I think
it's all very good.
Yeah, thank you, Dr. Pooja. It is said that for every 8 transfers, embryo glue gives you 1 extra positive result. So that is what the literature says. So again, the evidence is coming up for embryo glue or hyaluronon-rich transfer media. So let's wait for the evidence, and then we can maybe put it as a routine practice if it is shown to improve, because you really need to have a large cohort of patients to calculate whether it is actually useful or not. You can't just conclude in 5 to 10 patients in a month. That will not work. So I know centers which are doing 100 transfers, 200 transfers a month. They are using embryo glue routinely. And there are centers which have never used embryo glue, and they're also doing 120 transfers a month, and the results are comparable. So let us see what the evidence comes for embryo glue. I think it's still in infancy stage. So I don't think there are any more questions. And if you have any more doubts, you can log into our website and register for the forthcoming course. And we'll be discussing embryo transfer in great detail. It's a 4-session course. Those who have registered are already there, and others I encourage them to register. Dr. Pooja, any concluding comments from you, Dr. Pooja Bhayana? And then we can have a word from Dr. Pooja Gupta as well. Yeah.
So just the best thing is to have a gentle transfer with a soft catheter, and it will do wonders for you.
Questions on the chat box.
Sorry?
No, it was, I think, some kind of miscommunication. Yeah.
I still say the same thing. You have to do it like a thief. You have to go inside the uterus. You have to put the embryos. The uterus doesn't come to know somebody has come in, and you just come out nicely and quietly.
So she has summed it up very nicely. Go in like a thief and come out like a thief.
Thank you. There are questions on the chats that have not been answered.
So, Dr. Pooja, would you like to conclude the session, Dr. Pooja Gupta?
Please, there are questions on the chat box.
Okay, there are some questions in the chat box. Can you put in embryos after drainage of fluid? Okay. If there's a fluid in the cavity, what to do?
I
And
would like to
second-
wait only.
So you would like to freeze the embryos and no more, the embryo transfer should not be done. And Dr. Igbulo is asking, can you put after drainage of fluid? I think yes, but
People
drainage of
have
fluid-
done it, but the outcomes are not very good, I think. So when you have excellent vitrification facilities with you, why not to take advantage of it? Better to freeze the embryos and then transfer when the fluid is gone.
Which day E2 and P4 should be done in an HRT cycle?
I'm not into a practice where I go for E2 for my patients. P4 levels, yes, before starting progesterone, I get them done before starting the progesterone.
Okay, when you feel that the lining has been primed and you get
Yes,
the
when I'm giving embryo
Okay.
transfer date to my patients, I get the P4 level done. And the next day I start with the progesterone supplementation.
Okay. Okay, I don't see any more questions. And thank you, Dr. Pooja. It was actually a wonderful presentation and a lot of appreciation for you in the chat box. You must read it and feel good about it.
Thank you, sir. Thank you.
Thank you so much. Thank you so much for this wonderful session. Thank you, Dr. Pooja Gupta also, and Dr. Pooja Behana also. Thank you so much.
Thank you, sir.
I'm grateful. Yeah, I'm ending the
Thank
session
you,
now.
everyone. Yeah.
Thank you, ma'am. Thank you to all. Yeah. Good night.